Good afternoon, everyone. I thank the organizers of Receptor 2026 sincerely for giving me this opportunity. A very special thanks to Kumaravel sir for having me here. So we have heard a lot about the ifs and buts of diabetes management, the early combination therapy, and my prior speaker, Dr. Lakshmi ma'am, very beautifully spoke about the newest molecules on the block, the GLP-1 RAs. So now I'm going to do the opposite of all these. So I'll be talking about the diabetes care in resource poor settings. I think like many of you would have seen this topic and thought about it, and even myself. So I had a question. See, now the GLP-1s, we know that last couple of months or so, it's gone off patent. So even that medicine, which is supposed to be expensive, is becoming affordable. But whether this is reachable or accessible to the common man at the very rural downtrodden areas, and how do you tweak your guidelines and management protocols according to the population present there? Because we know that diabetes management is going to be difficult. So this is a journey of any non-communicable disease for that matter. So it begins with awareness. So awareness itself is a big job, because in poor settings, the literacy is going to be less, and the awareness about this disease to screen themselves for the disease is going to be very, very low, and followed by a screening and then diagnosis by a healthcare provider, and finally treatment. So this is the biggest challenge of all this in a journey of non-communicable disease, because we know that treatment is easy in our guidelines, so many algorithms, so many targets, but on paper, in our day-to-day life, it's not easier, because you know it is very, very difficult to convince the patient to listen to you. The patient, you might tell some 101 things to your patient, but the moment the patient goes home, he decides what is right for him, and he will do whatever is possible for him. So we have to tailor our approach accordingly. We try to do more with less. So we have to work smart with a very limited resources and time in our hands, and maintain the adherence, because the successful outcome of any non-communicable disease lies in the adherence to the management to prevent a good amount of HbA1c reduction, promoting to decrease in incidence of complications. So whenever we come out of our medical colleges, our expectation is something great. So this is what we all imagine ourselves to be, like heroes who is going to save the world. But this is what actually happens. We are beaten up at all points from all directions, and we have to make do with whatever is available, and we have to tailor ourselves to the public out there. And in India, most diabetes complications don't happen because we lack knowledge. They happen because the care is not feasible. Because people know what is their HbA1c, but that doesn't mean their HbA1c is under control. Guidelines, yes, lot of guidelines exist, but the guidelines are not implementable always. And drugs, yes, you have from A to Z, all the drugs you name for diabetes, you have it, but these drugs are not affordable. So diabetes is no longer a disease of the urban population. It has migrated. So you can see the graph on the left, the green curve. The incidence of diabetes in the rural population is catching up very vigorously, 15% compared to the 19% in urban population. And as you can see on the right side, as you can see here, in the poorest population, both the awareness, treatment, the glycemic control, almost everything is bad. So diabetes is aggressively penetrating into this rural and low income population. So resource poor settings does not mean rural areas alone. It also includes the low income settings of the urban areas as well. So people who are least equipped to afford the lifelong care it demands. So what are the risk factors of diabetes in rural India? We don't have specialist doctors. We have limited access to healthcare, lack of awareness and health education, and increased incidence of tobacco and alcohol usage. And genetically, we are already prone. See, these are some of the factors which are reversible. But on the other side, you already are genetically prone. South Asian ethnicity itself is a risk factor for increased diabetes. Sedentary lifestyle is catching away. We are moving slowly away from shifting away from traditional diets, and we consume more and more of refined carbohydrates and less of dietary fibers. And what about the glycemic control? Again, the glycemic control is very, very poor in the rural population, as you can see here. The percentage prevalence of A1C more than 9% is on the higher side. So we all talked about the risk factors, complications, the glycemic control, etc. What about the cost? What about the cost involved? So as you can see here, managing diabetes costs somewhere between 8,000 to 46,000 per year, and it does not cover the drug cost, doctor cost, the testing cost alone. The huge cost is contributed by the hospitalization due to the morbidities and complications developed as a result of poor glycemic control. So out-of-pocket spending is a norm of Indian healthcare. So it is very, very difficult to manage a chronic NCD like diabetes. So this is the barriers, the health system barriers, shortage of laboratory diagnostics, shortage of essential medicines, and shortage of trained doctors, and deep financial constraints from the patients. So this is a study which looked at the rural areas of 3 northern and western states. So this is what was found. So when they tried to identify the presence of the technology and the testing, the basic medications, etc., they found that the tertiary health centers, almost HbA1c testing, lipid testing, insulin, basic glucometers and metformin were universally available. But when you go to primary health centers, almost all the first 3 are not available, and only the basic glucometers and metformin is available. So we are fighting a complex progressive disease with deeply inadequate weapons. We have outdated weapons and we are fighting that with the same. So we have to adapt ourselves according to the change. So this is a list of challenges. So you know we all have all these technologies right now. So you have glucometers, CGMs, you have insulin pumps. On the other hand, in resource poor settings, you only have this: your basic insulin, your urine sugar test, and your basic blood glucose measurements. If you don't strengthen your existing healthcare with the available resources, your building can be strong with the technology, but the basement is going to be very, very weak. So how do we strengthen the basement? So this is what we are going to do. So we have to strengthen the primary care. We have to build a capable workforce. We have to offer digital solutions, because no village is without an internet Wi-Fi connection or without a smartphone nowadays. So you have again government programs, public-private partnerships, and also you can ensure community participation through adequate motivation. So how do you strengthen primary care? But I already talked about, we have a glucometers, urine sugars and metformin available. So you have to try to include the urine keto strips, because type 1 management is one of the crucial things that has to happen at the primary care before the patient is shifted to a tertiary health center. And along with that, you can make do with certain instruments, like you can accommodate a point of care HbA1c testing, which will tell you within 5 minutes what is the HbA1c of the patient. If you can't do it once in 3 months, you can at least do it once a year, so that you can know the actual glycemic control of the patient. And you can also provide a portable fundus machine. This is all connected to AI nowadays. You can remotely send the pictures to a person sitting at ophthalmologist sitting in the tertiary healthcare, and you can get the fundus reports in a minute. So now coming on to building a capable workforce. So any non-communicable disease for that matter, the human resource is the richest thing you can offer to build the care perspective. So you can start from the community level. You can include the ASHA and Anganwadi workers for door-to-door screening, home-based drug delivery, and fundamental lifestyle counseling can be given, because diabetes specialist nurses and diabetes educators, dietitians may not be available at the primary care level. So you can use this Anganwadi and ASHA workers to do the same. And you can train the medical officers and nurses to standard diabetic care protocols and initiate insulin at the start. And you can use telemedicine solutions to connect with the remotely with the endocrinologist and the physicians for the complex case referrals. So coming on to the digital solutions and telemedicine apps. See, I thought it must be a far-fetched solutions, but when I read through the literature, I was really surprised. There have been so many projects going on that have been helping rural areas, especially in Tamil Nadu and in northeastern states, where telemedicine solutions have offered a viable opportunity to improve the diabetes care. So you involve people living with diabetes to coordinate this care. You include the health system force, you share the task among the professional and the non-professional workforce, and you tailor digital solutions accordingly, and you also utilize the community members. So these are some of the studies which have shown in China and India where medication use increased by 20 to 26% when you use telemedicine based solutions, and also the mean HbA1c reduced by 0.8% by using telemedicine solutions. So what about the government programs and public-private partnerships? Already we have a lot of generic medicines, screening and standard care initiatives, national program for non-communicable diseases, Ayushman Bharat schemes, and you can utilize the help of National Rural Health Mission and societies like Research Society for the Study of Diabetes in India, which conduct camps and awareness campaigns across India, across the rural population. And this is a very good example. So it is a good example of public-private partnership. It's done by the central government, ICMR, along with Dr. Mohan's Diabetes Foundation, and along with the telemedicine help from the Indian Space Research Organization. So they had provided this fixed telemedicine van, which contains a fundus, as you can see, the fundus screening camera, and they were able to do all the screening tests for the complications as well as the assessment. And what they found that they screened a massive amount of 20,000 population, and the mean HbA1c decreased by 0.8% in 1 year, and only 5% of the patients really required referrals to a tertiary healthcare center. All the remaining patients were managed at that point at the primary healthcare levels. And this is a very beautiful example of our own program. That's the Makkalai Thedi Maruthuvam, where the health volunteers are used to dispense hypertension, diabetes and other essential medications. They check BP and blood glucose, and targeted interventions, educational services, immunization, everything is offered. So coming on to community participation, see, no disease control is completed without an active community participation, especially at the rural level where there is going to be a lot of gender and community based bias, education based bias, etc. So here you have to communicate with the village elders and utilize and the youngsters participation as well, and you have to engage lectures, puppet shows, quiz programs, kit, etc. And you can have a diabetic diet exhibition as well. So these are some of the community participation activities that has been carried out. So these are some of the pictures where the awareness campaigns, screening campaigns, and diabetes-free walkathon, etc. that has been carried out. So this is about the society level interventions. As a doctor, you are sitting in a place with a limited resource. So what are you going to do when a patient presents to you with hyperglycemia? So you know that there is no autoantibody, no C-peptide test available. So you use your clinical judgment and you use your discretion to decide what is right for the patient. So if the patient is old enough, overweight or obese, has a strong family history of diabetes, presence of insulin resistance markers, then you know there's a high suspicion of type 2 diabetes. And if the patient is young, lean, acute presentation, signs of ketosis or ketoacidosis, an urgent indicator of type 1 diabetes or a diabetic ketoacidosis. Astute clinical observation must bridge the gap whenever there is a lack of infrastructure. And you try to give the perfect care versus possible care. So the ideal guidelines recommend a HbA1c, C-peptide at diagnosis. They ask us to utilize continuous glucose monitoring, insulin pumps, etc. But in rural reality, you try to make do with a fasting postprandial or even a capillary blood glucose or a urine glucose, and you try to use metformin, sulfonylureas and bedtime NPH insulin. So this is a cost-effective pharmacotherapy ladder. This is again related to our conventional guidelines. You start with lifestyle and metformin, which is the foundation for obese patients, and then you switch on to sulfonylurea after 12 weeks of inadequate glycemic control, and if necessary for selected cases you can add pioglitazone, and still the sugars are not controlled, you can continue bedtime NPH insulin. So rule of thumb, lean patient consider SU or early insulin, obese patient maximize metformin plus thiazolidine-diones, and severe cost issues rely on sulfonylureas. So prioritize accessible low-cost agents to ensure long-term adherence in resource-limited settings. So you relax the targets, fasting less than 180, PP less than, so fasting less than 130 and PP less than 180. Relax further if the patient is going to be elderly to avoid dangerous hypoglycemia. And you can do a minimum screening for complication with a foot exam, regular BP check, and yearly fundus photography during their subsequent visits. And what about the lifestyle prescriptions? Again, it has to be frugal. You have to focus on the plate method using local affordable foods, prescribe walking as the best drug, and ensure adequate sleep. So this is some of the ways where you can adapt to the traditionally available millet, which is the ancient superfood, and also you can adapt to the traditional varieties of low glycemic index rice varieties, which can be offered to these patients. So this is a reimagined rural patient journey. So awareness and screening supported by ASHA workers, diagnosis supported by pragmatic subtyping by clinical decision management of a doctor, and basic glucometer and urine test at a PHC. Treatment supported by cost-effective medicines, and maintain adherence monitoring using again ASHA workers and the community participation. Use relaxed glycemic targets. You can use mobile applications to make sure they don't miss their follow-up and they fall on track. A cohesive ecosystem ensures patient doesn't fall through the cracks of this resource-poor settings. So to summarize, the 5 golden rules of frugal care: start simple, rely on basic diagnostics rather than waiting for HbA1c or a C-peptide. Prioritize adherence. A mediocre plan the patient follows, the patient sticks on to is better than a perfect 100% technology-wise plan. Use affordable drugs, maximize metformin, SUs and NPH, escalate early, do not succumb to clinical inertia or insulin myths when basic oral therapies fail. Educate constantly, use local language, focus on affordable local traditional diets, and make walking the primary prescription. Because in resource-limited settings, the best regimen is the one patient can afford, understand and follow. So thank you. We cannot solve our problems with the same thinking we used when we created them. We have to adapt accordingly. Thank you.